So we have called upon Dr. Siddhartha Datta from Fortis Hospitals and Kidney Institute to present his clinical case.
Good afternoon, everybody. My colleagues, teachers. Myself, Dr. Siddhartha Datta from Fortis Hospital. The patient, 59 years old, female patient, complains of intermittent left flank pain for 1 month. The patient pain is dilating in nature and intermittent for 1 month. There is no aggravating or relieving factor. Pain is associated with significant unexplained weight loss, and pain is not associated with any fever, hematuria, lump or swelling, any urinary frequency, urgency or difficulty in urination. There is no history of any headache, palpitation or sweating, no history of recent onset diabetes. Patient is not associated with any jaundice, chest pain, cough, loss of consciousness or convulsion. Patient has undergone LUCS for 30 years back. There is no significant history of personal history or menstrual history. He received multiple courses of antibiotics for this patient for these symptoms, and no history of taking any immunosuppressive drugs. No history, family history of any hereditary disease. A general survey, patient ECOG scale is 0, and no clubbing, jaundice, edema, sinuses, pallor, edema present. No palpable lymph node in cervical, axillary or other sites. Local examinations within normal limits. Liver spleen not palpable and renal angle not tender. Parectal, parvaginal examination and other systems no abnormality. Investigations, there is no significant abnormality in investigations. Creatinine level is 0.8 and eGFR is 70.5 ml per minute. And LDH is slightly raised, that is 450 unit per liter. Serum calcium marginally raised, and serum cortisol level and urinary VMA and metalaphrin are normal. Urine routine and culture test are normal, and there is no proteinuria. Then we go for USG. USG detected that abnormal, well-defined, homogeneously left mass in the suprarenal region, which is 12 into 10 into 9 centimeter. This is the mass we can appreciate in the suprarenal region. Then we go for the CECT of abdomen. It detects there is a heterogeneous enhancing mass of 11 into 10 into 9 centimeter of the left suprarenal region with loss of fat plane between the kidney and adrenal. Since the mass is more than 10 centimeter, we go for HRCT as well. We detect no mediastinal or abdominopelvic, no mediastinal lymphadenopathy. Opposite kidney is normal. This is the mass. We can appreciate there is a enhancement in left suprarenal region. My provisional diagnosis is this is a case of left-sided adrenal tumor infiltrating into the upper pole of the kidney without any lymphadenopathy and no metastasis. We plan for left adrenectomy with a consent of left nephrectomy if needed under GA. Intraoperatively huge complex of adrenal tumor with hemorrhage seen, approximately 10 into 12 centimeter, with gross adhesion laterally with swath displacing and infiltrating the upper pole of the left kidney. There is no proper demarcation can be made in between the normal tissue and tumor tissue in the kidney, so we go for the radical nephrectomy in this case. Post-op course is uneventful. This is the histopathology. It says that is suggestive of a large B cell non-Hodgkin's lymphoma, high grade, with tumor into the perinephric fat and renal tissue, soft tissue. We go for immunohistochemistry. It detects the CD20 cell positive, MAM1 negative, and K167 80% positive. So, in conclusion, we can say that this is a case of diffuse large B cell lymphoma, non-GCB type. This is the IEC showing that tumor cell with large vascular nuclei and moderate cytoplasm. This is showing the CD24 cell positive. For the treatment, the patient was educated about the disease. He was referred to a medical oncologist for the appropriate chemotherapy regime of this lymphoma of adrenal region. He then advised for staging of the disease. Post-operatively, the whole body PET CT scan was done, which was negative for bone or any other lymphoid tissue. This was the post-op PET CT. It detects there is no other lymphoid tissue other than the detected in PET CT. Before the initiation of treatment, serum LDH, as per advice of the medical oncologist, serum LDH, sodium, potassium, creatine, phosphorus, uric acid, calcium test was done. Because of these patients of non-Hodgkin's lymphoma can easily precipitate tumor lysis syndrome in chemotherapy when chemotherapy starts. He then was initiated on standard treatment with R-CHOP regime for 6 cycles. Clinically, the patient has follow-up. Clinically, the patient is doing well and gained weight and no P symptoms patient at present. Post-op follow-up with FDG PET scan shows no evidence of any recurrence at 6 months. Thank you.
So what is the primary diagnosis? It is NHL of kidney or NHL of heart?
Yes, sir. Actually, in histopathology also we could not make out what is the primary origin of tumor. So as the kidney renal lymphoma is more common, we think that it is renal lymphoma infiltrating into the adrenal.
Is there any way you could have made a pre-operative diagnosis?
Yes, sir. I can make pre-operative diagnosis, but since this is a large tumor of more than 10 centimeters, we can do biopsy pre-operatively. That could clinch the diagnosis. In retrospectively, we can think that. But since we take it as a renal tumor infiltrating into the adrenal, so more than 10 centimeters, anyway we have to take out the tumor. So that's why we don't do biopsy. But in retrospectively, we can think that if pre-operative biopsy is done, that could clinch the diagnosis of lymphoma, and that could properly chemotherapy is the main treatment of that.
The pre-operative diagnosis was that it was an adrenal tumor.
Yes, sir.
In CT scan there was
Not a renal tumor.
no diagnosis of renal lymphoma.
What was the CT protocol? You found a 10 centimeter tumor in the left
So
side.
actually the CT was done outside. So adrenal CT protocol was not done here, which is usually non-contrast CT, arterial phase and delayed 15-minute delayed phase or 3 millimeter cut. It is not done.
Maybe there have been situations where large renal lymphomas, you can't remove them. They're expensive. If it had not spread to the adrenal and it spread somewhere else, sometimes the radiologist can point out characteristics suggestive of renal lymphoma, especially with a high LDH and a high beta-2 microglobulins. And I have, they're all anecdotal examples actually like this. And patients
Yes, sir.
vanishing with tumors vanishing with leaving behind after the end of the surgery, you see a normal kidney.
Actually, pre-operatively we could not diagnose the case actually.
There was no hematuria.
No.
Only pain.
Only pain. Left flank pain with significant weight loss.
And not, it was a non-functional tumor.
Non-functional tumor. IPGME&R, metavastatin and cortisol are all within normal limit.
So because if you think it's a renal tumor, you might find a pain between the kidney and the kidney.
Yes, sir. But in this case, the CT clearly find that there is loss of cat plane between kidney and adrenal.
If it is an adrenocortical carcinoma, yes, it will be infected. Lymphoma, difficult to say because the kidney lymphoma.
Yes, sir. That's why we have rechecked it with pathologist also. They could not say that I have specially checked it is an adrenal origin or kidney origin. They said that we got the make out.
What was the incision that you used?
Sir, left flank extrapedural incision.
Can you describe the incision?
No, sir. Actually, 11-3 cut in 11-3 supracostal incision. Flank, left flank.
Retroperitoneal flank incision.
Flank incision.
Transcostal.
Transcostal.
How do you perform a splenoportal rope? In this case, the plan was to do an left atrial. So how do you perform a splenoportal rope? What is a splenoportal rope?
और बीच থেকে কেউ বলো না anyone contribute
Splenoportal rope refers to mobilization of the spleen and the tail of the pancreas.
It is difficult in retrograde spine thesis.
That is the first step before performing a left atrial. So once you mobilize the spleen by incising the linear ligament, then the spleen begins to mobilize medially. And along with the spleen, the tail of the pancreas will also move medially. It's called splenoportal rope. You may have seen in those days when open surgery was done, the surgeon used to actually mobilize the spleen and the tail of the pancreas and bring it out of the abdomen and put it onto the right side, so much so that the left adrenal was completely visible in front of it. So that is a splenoportal rope.
This is much really seen in laparoscopy. If you do a lab adenectomy, that is the first step. You have to remove the spleen along with the tail of pancreas, the whole of the pancreas to the medial side.
looking back at the imaging CT would you have gone for extraperoneal approach or you would have gone for the intraperoneal and why
Sir, intraperitoneally, I like to go because of high vascular contribution.
Yeah, you said that the splenoportal role is easier in
Easier in
extraperitoneal. It's difficult in extraperitoneal. So looking at the big ones, almost going to the medial side axis. So you expected a little bit large, you didn't expect a renal tumor as well. So it's more an large adrenal tumor, which could be adrenocortical carcinoma rather than large tumor.
Thank you so much.